Welcome to the Health Catalyst podcast, brought to you by YPO. Here we talk about the business of health innovation, and I sit down with industry leaders who have been in the trenches. My goal is to share the lessons and provide practical and actionable advice to help you launch, grow, and scale your business. I am your host, Rodrigo Hute. Hi everyone, and welcome to the podcast. Today, my guest is Dr. Liz Kuo. Liz is a health tech executive, entrepreneur, physician, board director, and she specializes in scaling digital health companies. She is also currently the Chief Commercial Officer at Everly Health. And also, she's the author of a great new book called Digital MD, which I highly recommend. And in today's episode, we'll be talking about her book and also about how to navigate the complex stakeholder ecosystem in U.S. healthcare. Liz, thank you so much for being here today and welcome to the podcast.
Thank you for having me.
I'm very excited, and I enjoyed your book. I read it from beginning to end, and
did you? Okay,
I did read it. I read the whole thing, and I have to say that I learned more about the complexities of U.S. healthcare. You know, I come from Latin America, so for me, it's like learning more about how the complex system in U.S. healthcare is very interesting because it's very complicated. And you talk about the complexities of the 5 Ps, and the 5 Ps, being payers, providers, patients, pioneers or entrepreneurs, and policy makers.
Yes.
So I just wanted to start by asking you, like, what motivated you to write, your new book, Digital MD? You are very busy. You have a lot of things going on. So what was the motivation behind it?
Sure. It was, I would say, inspired by 3 core traits that have guided my own careers. One was that I think if you can be in a role as a CEO and an entrepreneur that really changes the way things are done in healthcare, you can have a huge impact. I think another commitment to just data-driven clinical approaches. And then the third was thinking about a strategic focus on the healthcare system. So meaning, I think for the first thing, it's how do we as leaders and people that can really movers and shakers change the healthcare system. I've seen firsthand the barriers that exist to prevent innovation. Also, there's a disconnect between, we talk about groundbreaking technologies that are available versus adopting them, and what actually makes a company successful isn't always a really good technology. It's understanding the stakeholders and how you build your moat and build a good mousetrap. But also just, I think as a leader, I've started a few companies. When you're in a CEO position, you can really affect like millions of lives. And so how do you motivate people was something that I feel very strongly about. The second was this idea of just data-driven decisions and thinking about the gap in understanding healthcare professionals and what physicians, choose to do, or nurses, and how they write for prescriptions versus the technology that's developed versus what things are reimbursed for. Even, for example, when you go to ER, if you have a cut, you could have something called the dermabond. It's like a glue, or you can stitch. And so the decision between those two depends on time, reimbursement, but also some of those things aren't always transparent when you walk into an ER and what you're going to pay in the US. So really creating some transparency around that. And then just the mindset of focusing on efficiency, cost structures. For me, it's always been about how do we think about case studies in telehealth, and right now that's table stakes post-COVID. So how do you think about remote patient monitoring and how AI is going to change the way that we think about healthcare in general? Because right now AI, I think personally, it's making knowledge very, instead of scarce, very available. So you have information with diagnoses and treatments everywhere. And so it's going to change the way that we think about and treat patients.
Absolutely. I'm going to start with a basic question about who pays for healthcare in the U.S. And most people that work in the health industry in the U.S. have heard that healthcare expenses in the U.S. are on the rise. So I think it's we are at around $4 trillion. This represents around close to 20% of GDP, and uh, when I first moved to the US, I was curious about like who's paying for US healthcare. And in my understanding, and I wanted to ask you the question if this is accurate or not, at a, in a simple way, I break it down in three ways. I would say around 50% it's government funded by CMS, which is Medicare, Medicaid, and federal and state programs. But around 50% is government funded. Around 30% it's employer-based private insurance, more or less, and the other 25% or so it's consumers, whether they are paying out of pocket or contributing to insurance premiums or so on. Is that roughly accurate, or am I missing something?
Yeah, and I think even for public payers, with CMS, you break it down into not only Medicaid but also Medicare, and Medicare is the more retirement population, post 65. There are Medicaid that's a bit more subsidized. It's also state by state, much more governed across states versus Medicare is more, I would say, more of a national level. Those estimates are correct. Because we have employer-sponsored healthcare, there's also within the commercial line of business, I think you can break it down to two types. There's something called self-insured employers, which I talk about in the book, which is those that are companies that are large enough to basically take on the risk of any kind of structure. So they can dictate what kind of medications they want. They can dictate what benefits they're going to cover, versus those that are fully insured, which goes through the payer side and lets the payers more so dictate. So there are so many different ways to slice it. But I think your general estimate is correct. Then there's also those that are patients paying for wellness things. It's not necessarily, I want to say, under medical necessity, but it's things like sleep aids or medication over the counter, or things that are focused on even exercise regimens and the Fitbits and Aura rings and whatnot. So those, if you consider that being also part of it, you will then slice it a little bit differently, because what's medical necessity versus what's a wellness app and a wellness service is slightly different.
Yeah. Okay. That makes sense. And you spend quite a lot of time in your book talking about the complex network of stakeholders.
Yes.
And this happens everywhere in the world, but I think in particular in the US, it has its nuances. So yes. I wanted to ask you questions about that, and I want to ask you about, like, help me understand, the psychology and the motivation behind each of these different stakeholders. And
yeah, sure.
Please take your time. But we have patients, we have payers, we have providers, we have government entities, and I just you go into quite a lot of detail in your book. So I suggest everyone to get a copy of the book if you want to learn more. But how would you summarize, kind of the psychology, the motivations of each of the key stakeholders?
Absolutely. So we can start with patients, because I feel like they're at the center of everything. And really, the goal is to focus on outcomes. So patients oftentimes think about affordability, but also access, and understanding what outcomes will be given to them based off of what kind of procedures, behavioral changes, medication, treatment, surgery that they take. Patients often prioritize the ease of use. They prioritize trust. Their psychology is around if the solution impacts their quality of life. I've seen a lot of also personas, like profiles of those that care about authority versus ease, versus someone who's so busy and doesn't really think about healthcare. So they want it to be just not only easy, but something they don't have to think about. So decision-making is really heavily influenced by cost, but also on convenience. I think for payers, it's, as we talked about, both insurers, which are just the larger payer side, but also employers, self-insured employers. They prioritize managing risk and reducing cost. So each year premiums are going up in the US. It is a big, line item for CFOs of all companies. And so they have to evaluate the interventions based on the return on the investment through not only reducing claims, so medical claims and things that are not only premiums, but things that are increasing over time, but also better population health and minimizing what I call high cost episodes. But there's sometimes high volume, which is things like musculoskeletal issues, mental health, but maybe lower cost to some extent because there's not surgeries. But there's also lower volume, but very high cost. It could be a C-section for someone versus also a neonatal ICU stay or someone who needs surgery. So CFOs have to think about it that way, but so do large payers when they're managing cost structures. And even for payers, I talk about in the book, where they are held accountable to something called the MLR, so medical loss ratio. They have to spend a certain percentage of the premium dollars that people are paying on specifically medical care. So at the end of the year, and usually Q3, Q4, they have to think about how much do we spend on the patient. And if they have extra, something called the admin budget or left over, they do want to spend on wellness or other things that they can add on. Or another thing that payers also do is try to make sure that they continue their certification with being able to enroll new patients. So STARS and HEDIS ratings on payer side is really important. This is where they end up caring very heavily about are patients getting their colonoscopies and mammograms, because their ratings matter depending on that. And this is where Everly Health, we do something called gaps in care, where we do diagnostic testing and we help payers meet those metrics so that they can close their gaps and have the right to re-enroll patients, because they're allowing more patients and or their own members to get the right care. If you think about also providers, they're just clinicians, nurses, doctors aiming to really deliver high quality care. But for them, there's a lot of questions about how do they manage the operational structure with the administrative burdens that occur, sometimes a lack of amount of time that they can spend. But they're thinking about like efficiency, and when they choose things, clinical validation, sometimes it's also to make sure that the hospital system or whatnot is reimbursing them for their right time. But it's also aligning not only on reimbursement, but on structures to guide their decisions. Like if there's a new medical device or a new pharma company or something else that's even better, they want to make sure that they're making the right decisions for patients. I break it down too, because in the book, sometimes providers, of course, have to and want to do the right thing, but they are confined oftentimes within a certain structure of either reimbursement codes and or CPT codes and or how they're thinking about their time spent and what they need to do. So it's a very interesting part of the whole ecosystem. And then you talked about policymakers. So these are people that are, not only the CMS regulators, but also FDA bodies and those that optimize for public good. Impact, they look at equality, they look at adherence to policy. Even right now with the FDA, they also have their own healthcare kind of AI framework. And so they're thinking about the long-term systematic sustainability of certain policies and what this means to contain costs. And then lastly, I think for pioneers, I always talk about you can be a pioneer within a large organization, even if it's you're not the CEO, you're not the founder, and you can be a founder of a company. But I feel like pioneers are everywhere, and this is where the book is written to help anyone think about the future of where healthcare can be.
Yeah, definitely. There's a lot of detail on that in the book, and let me ask a question around value-based care, which is this
Yes.
Payment contracts that my understanding is that the goal is to optimize clinical outcomes, reduce costs, and make also providers accountable for delivery instead of just delivering a fee for a service, right? How is that? And my understanding is that value-based care has been going on in the US for 10 years or so, but people talk about it as if it's the new thing. So what's your opinion on that? Is it just a fad? Is it something that it's some people are doing it, but some people don't? Do they benefit certain parts of the stakeholders, but not others? How do you think about that?
Yeah, I think so. Providers are oftentimes held accountable to value-based care because payers that are ultimately the ones footing, I think, the bill and the reimbursement are saying, we want to tie you to outcomes rather than just paying per surgery or per intervention, can we figure out how to say, these are the premium dollars I want you to spend, but I want you to spend it under a certain amount of money. And how you want to spend it is dependent on you. But we have this contract right now that says you take the risk just like we do from a payer perspective. And so they put the onus on providers. I think what has made it difficult was that a lot of value-based care contracts were actually structured where there's upside, but there's no downside risk. So if a provider at the end of the year is like thinking about their numbers, and by the way, there's also sometimes lack of transparency and providers not knowing where they stand. So it's a lot about, as we talked about from the beginning of the podcast, data at the right time and making it accurate and insightful and can help providers change their behavior or know how they compare to other peers is key. But at the end of the year, when providers don't have downside risk, they only have upside potential to gain more, they may say, well, I don't think I'm going to get my upside, so I'm just going to continue the way I've been managing. But when they're taking on downside risk, when they could lose money, then I think it ends up being much more interesting. And a lot of providers don't like that kind of contracting. So payers have tried to do different types of structure to, especially in technology, to streamline the workflows or increase patient throughput through financial goals. But you're right. Some models have really worked, some haven't. And I do think, you asked, does it benefit patients? It ultimately can. The value proposition often includes not only cost savings, but hopefully maintaining premiums and improving outcomes. But there are also, downsides to it, including how would a patient fit into that model? Most patients ideally want a physician who has their best interest in mind, which most, I would say, providers do. But when you're in this kind of, I would say, stakeholder ecosystem, it's not always, the incentives are not always entirely aligned. So I do have faith that value-based care continues to change, and with more data and more insights and more interventions that are useful, even mid-year, for risk management and keeping healthcare costs low, I think it can contribute and help everyone.
Yeah, I mean, from my perspective, the spirit and the intent of value-based care makes total sense.
Yes.
Don't focus on volume, don't focus on transactions, focused on, delivering the best quality of care while reducing costs as much as possible and
yes.
share the risks and the upsides. It seems to me as a good partnership.
Yeah, I think so.
The devil lies in the details, right? As they say, and each case and each therapy or each procedure can have different trade-offs or potential tensions, between stakeholders. And you gave an interesting example in your book about an Everly Health product. I think it's the at-home colon cancer test. And you talked about, you said, how could a product like that could potentially benefit everyone, every stakeholder in the kind of in US in the healthcare system. And let's talk about that for a second. Just to take as an example, this at home, it's called FIT. Colon cancer test by your company, Everly Health. And it definitely has a benefit for the patient, right? You buy it online. You don't need a prescription. That's my understanding, because it's a screening test. It's not a diagnostic test. You get it at home. You collect your samples, and then you get results. And for the payer, it also makes sense because you are using a low cost screening technology that could prevent people to then get expensive colonoscopies down the road. But then, the part where I think there may be some tensions, it's on the provider side, because the provider, the provider, they are used to seeing patients to do colonoscopies, and by having this at-home screening test by, a company like Everly Health wins, the payer wins, the patient wins, but the provider might not win, right?
Yes.
So, that's my quick analysis as I go through the different stakeholders in this example. I'm just wondering if you see it the same way, or if you think there is a scenario where everyone in every stakeholder can benefit and win from something like this. Do you see it differently?
I do. So I would say I see it similarly. So it's called the fecal immunochemical test, and you can order it even with Everly without a provider ordering for you. You can order at our site. But I would say we have a physician network that we hire so that they do check to make sure that any test that's ordered is right for the patient. And what's interesting, though, the reason why there's some tension, you're absolutely right, with the provider is that providers make money off of like any kind of colonoscopies. Yeah. But what we're seeing is that most Americans, actually 1 out of 3 adults in America that have a recommended age of screening don't get a colonoscopy. So that's 33%. In 2020, I wouldn't say even 1/5 of adults have never been screened. And so when you're thinking about just the general numbers, if you can have someone who can, and it's not that fun, but it is like you poop onto a test sheet and then you just put it in the mail and you can figure out if you potentially have colon cancer. It is a shorter, easier way to do it in the comforts of your own home than drinking a lot of fluid, organizing the colonoscopy, having to schedule someone to pick you up from it because you can't drive after that, because you're put under anesthesia when you do a colonoscopy. So a lot of the payers actually benefit from, like you said, a lower cost structure, earlier detection that reduces expensive treatment down the line if someone has full-blown stage 3 or 4 colorectal cancer. I think providers do appreciate a lot of the tools. When we get a positive fit test, we actually send a PCP letter. We send it to their primary care doctor to let them know this patient is really high risk. They need to be followed up with a colonoscopy immediately. And that kind of screens enough people so that they may not get the colorectal screen until they have us. Patients also find the test, I want to say, accessible, again, less invasive because it's not a scope up through your anus, right? Not through your body, but it's actually just you poop onto a stick. But you're right, the tension exists. Providers sometimes worry about reimbursement or follow-up or balancing remote care and versus in-office visits. So we've tried to align our incentives in the correct way with payers to say those that have not been screened and you know that they need to get screened, how do we help you reach out to them and get this test to someone's home?
Yeah, absolutely. I see the benefit. I think there's more benefits than downside. But I can also recognize that the tension can generate to someone. So
without tension, it won't be fun, right? And without tension, there won't be innovators like us excited to sort of change the way that we think about it.
Absolutely. There is a few trends that I've been noticing in the market that I would love to get your take on, your opinion. So sure. I'm going to go through some of the stakeholders that we've been discussing. So the first one is patients, and when I ask myself the question, what do patients want? And you already touched on some of these things, but one that is very clear, it's access. People need access to doctors and care. And for some reason here in the US, it's particularly challenging, to have access to care. The other one, it's competence. Patients are looking for competent doctors. The third one is compassion. And the fourth one, it's coordination, like coordination between.
I like those. Those are really good C's.
Yeah. And so I want to touch on one of those C's, which is the second one, which I call competent doctors. And up until now, you could find really good doctors and doctors that are very well educated, let's put it this way, or have more experience than others. But my question to you is, with AI, in my opinion, it's coming to democratize medical knowledge. So you are going to be able to, if you think about AI for clinical decision making, every doctor everywhere in the world will be able to access the same information, the same clinical trials, the same analysis in a click of a button.
Yeah.
And so my question to you is, do you think that because of AI, we're gonna see not a big gap between the best doctors and the less well doctors, and everywhere you go, you're gonna be able to get access to very competent doctors because they are gonna have a co-pilot, which is AI, and in turn they're gonna have access to the information that they need. It's just that tool and that product doesn't exist yet, but because of AI, my futuristic mind tells me that maybe in a few years there is a possibility that we're going to be in that scenario. So what do you think about that?
I do think that it's evening out the playing field a bit. So even for surgeons right now, there's AI guided. It'll tell you should be looking at this. This is the product, or this is the cancer, or this is what you should remove. That is definitely going to change. I think AI has a lot of uses. As we talked about earlier, the scarcity of knowledge is no longer there. So the next step is certain physicians, doctors, nurses, all will have to learn how to incorporate AI. Some of them may be slower to incorporate, which is also going to be an issue. So those that don't, I think, will fall behind in quality. But I think, if you think about the AI use cases that are going to equalize provider competence, there's a lot of use cases for it, from everything from surgery that we've talked about to the ability to not have to predict with your own eyes. When a patient comes into the ER now and you input all these things, symptoms that they're experiencing, there is a very clear diagnosis and a list of things that you have to eliminate and tests that you can follow through on. So I think that is going to be the future of how healthcare is done, AI-powered differential diagnosis at the point of care. So it's disrupting, I think, a lot of the real-time impact of emergency departments with these co-pilots, like you mentioned. There's also protocols for chronic disease, like primary care doctors managing patients. So they can create very hyper-personalized treatment plans based on genomics, lifestyle data, wearables, that we have, historical responses to interventions. It can ingest all of that, Facebook profiles, social media profiles. And I think the business opportunity, where there are lots of companies thinking about this, is how do you integrate it into everything from behavioral changes to drug delivery to creating, I would say, like intelligent therapies that adopt in real time. And I think the unexpected impact we haven't talked about yet, but patients may not need frequent clinical visits anymore. In the future, there will be a lot more remote monitoring, AI-generated protocols. I think that will deliver very useful, intelligent information. I also expect to see a lot of interesting work with the price transparency, actually. So being able to, as a consumer, think about which companies or even which MRI I should go to, because this one charges me this, and this one charges me this, and perhaps payers steering you to a cheaper location with equal quality, with real-time patient pricing models. I think that could be really interesting. So patients can also compare. If they're not using their payer, maybe they compare with an AI-powered platform to tell me where I should go. I think there's going to be a lot of use cases there. Even on top of that, I would say AI-driven workforce transformation. We've talked about the shortages of skilled professionals. And now that it's evening out the playing field, how do we create virtual specialists capable of handling routine diagnostics or supporting primary care doctors if they can input their symptoms? There's, I think, a lot more business opportunity there. I recently talked to a company, it's a public company CEO, who said that in healthcare that they are now tracking even, for example, facial features. In the past, pediatricians couldn't always recognize differentiation of a normal facial feature, but what it could have linked to a certain genetic diagnosis for a child, let's say a newborn. or a 6-month-old or a 12-month-old. But if you input all this information and it recognizes facial changes, they can actually now identify even rare diseases just through recognizing changing an eye color, the way that this cleft palate was done. So there's a lot, I think, that will be changing in the future of healthcare.
Yeah, I love it. That's super exciting. The other piece that I noticed here in the US, it's access. Access to clinicians. And you mentioned earlier that providers sometimes they get reimbursed.
Sure.
Based on what the insurance company, whether it's private or government, they say. They cap their service. And what I've been noticing also is that there are certain providers, physicians or groups or clinics that choose not to be in the system, and they only charge that you can only go there if you pay out of pocket. And I see that as a missed opportunity for patients, because sometimes they might not be able to access the best care or the best provider, and they have to limit themselves with whatever they can find it within a network. So what do you think about that? Do you think it's changing? Do you think it's policy? Because if you are a patient, whether you have Medicare, Medicaid, or your employer-based insurance, you want to be able to access the best possible care, right? And if that physician is not in your network, then you either have the money to pay out of pocket or you miss that opportunity.
Yes, so access has always been something I'm very passionate about. I think that will not change, quite frankly. I think the best providers will tend to have a certain threshold for what they expect to allow them to make a profit and or break even. And so when they think about those that have choices of patient selection, I think that will continue. I do see, though, that we talked about evening out the playing field. So being able to have ideally elevating providers that perhaps traditionally haven't been as good at diagnosis or treatment, elevating them through AI and the modeling. I think one thing that payers also do is their job is to look at quality of providers, right? And so they sometimes don't re-enroll someone in a network if they don't feel like those providers are good. But you're right, sometimes some providers don't take Medicaid, for example, or they'll only take someone in a concierge medicine practice. I don't see that changing. I do see, though, that payers are now thinking about, if you want to maintain your practice and you want us to give you volume and you want to be part of our network, we're going to hold you accountable to this level of quality. And we expect you to hopefully leverage the AI tools and other things to improve your not only diagnostic accuracy, but also your treatment plans and using value-based care and those types of arrangements to get that set up.
Right. Yeah, that makes sense. Yeah, thank you for that.
I think this will be true for a lot of tiered healthcare systems, though, that you will always have providers who are able to charge more, whether it's Canada or other places with a different system. I would say you probably see it in Mexico too.
Yeah. All right. I would like to shift gears a little bit and talk about, how to sell to the different stakeholders that we were just talking about. So when you think about a commercial strategy, a go-to-market strategy, and you're currently the chief commercial officer at Everly Health, so this is very relevant. And you also have a lot of experience. You have experience selling to stakeholders in a direct-to-consumer fashion, in a direct-to-consumer model, selling direct to patients/consumers. But you also have experience selling B2B and also in a B2B2C model. So I was just curious, what are some of the unique challenges and opportunities when you are selling direct to consumer versus on a B2B model? And in particular, and you mentioned this in your book, which you might have the best product and the best technology, but not because you have the best technology, that means that you're going to win. So in healthcare, distribution it's key, right? So you really need to be able to get that product to market and have a clear commercial strategy. So what can you share, and what have been some of the key lessons when you when you sell direct to consumer and also in a B2B environment?
So I think I kind of see it as like a different type of model progression. So generally, a lot of companies, they start out by saying, is this medical necessity, or is this kind of wellness and health? If it's medical necessity, meaning it's diabetes or chronic diseases, something that costs a lot for the health insurance company, they may have a model for the enterprise model, or to get a payer or other people to pay for it. But if it's not, it's on the wellness side. It's usually, quite frankly, more on the consumer to pay for it. Something like a sleep aid or exercise regimen or wellness tracking. And for the consumer side, consumers are thinking about more accessible simplicity. So it could be a mobile app for mental health. But once a payer gets interested, it's usually when they know that there's a return on the investment. And that's when you can start structuring more of a B2B business model. And for payers, they're thinking about, and these are insurers, but also self-insured employers and CMS, Medicare, Medicaid. They're requiring things that are much more specific to cost reduction or workforce efficiency, or sometimes it's also accessibility and availability. So I would say payers will pay for it based off of what they could do, what this company could do to change the cost structure. Early diagnosis could lead to cheaper treatment costs for cancer. But if it's generalized, let's say genomic data, and it doesn't really change intervention, payers are not interested, right? They're not thinking about, this or something like 23andMe. Why would it not be reimbursed? It's because there's no direct medical change or intervention that would reduce medical costs down the line. And so I think about it that way when I think about enterprise models. Same with Everly Health. We spend a lot of time working with the payers to say, if we could diagnose chronic kidney disease early, stage 2, we could prevent a dialysis requirement down the line. So those are very strong medical changes in interventions and helping someone control their diabetes better so that they don't down the line have to even suffer more medication or a foot amputation or other things that could lead to, if people have uncontrolled diabetes. I think the other thing that you mentioned briefly, and I think this is what you're getting at too, is the B2B to C model. It's how do you convince the enterprise, the payer, the insurer, or the employer to pay for it, but then you get the consumer to buy into it. Because that is another interesting model where first you go after consumer, then you go after a payer to pay for it, but then now you have to go back to the consumer and say, your company is now paying for this. How do we partner with you to make sure that you have access to this? And this is where we spend a lot of time engaging with the consumer, whether it's through all the different contacts, phone, email, text messaging, thinking through how do we engage the consumer to help share the benefit. So those are some of the challenges for, I think, the evolution of how a healthcare company manages through that.
Great, thank you. That was a great explanation. Is there? You mentioned Everly Health as an example, like approaching payers who are interested in reducing long-term chronic disease management expenses by using an early stage screening. Has that worked with a payer? Like, have you been able to convince the payer to subsidize your tests and give their patients the Everly Health tests?
Yes,
and pay for it?
I would say we have, because they have certain HEDIS stars metrics that, again, to allow them to re-enroll patients next year as part of their business model they require. But also we share a very strong ROI with them, right? So tailoring the message to articulate very early that there's cost containment down the line. You can early diagnose, leads to early treatment, leads to early intervention, and collaborating with them on repeaters every year so that the patients actually start to know us and trust us. And we leveraged not only the outcomes data of better cost containment, but also early adopters and how easy it was to use. And we talked about what consumers really care about in the B2B2C model, especially as thinking about loyalty, fostering emotional connection, thinking about now that we have a contract with payers is how do we scale this and make sure that our consumers are seeing this as a benefit.
Okay. So a payer would say, okay, I get it. I'm gonna buy the X Everly Health test, and
Yes.
I'm gonna give it to my patient population at the end of the year because they have this additional budget. You mentioned Q3, Q4. Is it only because they're using that additional budget in Q3, Q4 that they are willing to do this, or are they already convinced that they want to do early stage screening because they are convinced that they are saving costs down the line?
We've started off both initially with the later stage Q3, Q4, but now we're seeing a lot of payers with the data that we have doing it much earlier, Q1, Q2. Actually, it's even better also because it evens out sort of our revenue stream too, because they're seeing early diagnosis even in the beginning of the year can actually try to change metrics over the course of the year. So we're seeing things like wanting to do annual wellness and annual screenings that are now useful, because I would say on top of that, telehealth used to be sort of an interesting concept of urgent care, but now it can be done with annual wellness. You're seeing Amazon and One Medical and some of these ways of doing virtual home management. So we're adding to the value proposition of home screening with testing with the PCP model.
Yeah. So the payer would buy you. Do they buy an inventory of your tests and then they give it to the patients as a gift as part of their insurance coverage, or do the patient has to request for the test?
They send us patients that they want to target, so we focus on that.
Okay.
Yeah.
Okay, I see. I get it. All right.
Great. Thank you very much for asking these great questions. I think these are very, very good and very relevant, because I hope that more and more people can ask these questions and learn from it and try to build incredible companies around it.
Yeah, no, thank you. I have one last question before we go.
Sure.
The digital health market has had its ups and downs, since COVID and recently with funding and IPOs and so on. What's your prediction? Like, what do you think is going to happen to digital health over the next couple of years?
I think it had to have a reckoning. I think there was such a bullish run for it for so long during COVID. I think we will come to see it even out. I think there's still some hesitation across investing in digital health at crazy valuations like we did before. But I actually do think the ones that will really prove themselves are ones, again, that we talked about: true ROI, true profitability, managing patients in the right way, and seeing not just the ability to scale early adopters, but really becoming a bread and butter scope and opening up the market. I see it still I have a lot of faith in it. I think there's all this new technology, and especially with AI and all the opportunities to reduce workforce burnout and make things much more efficient at a cost structure that makes sense. So I'm looking forward to it, I would say, coming back I want to say maybe in a year or two. Yeah, okay. We'll talk in a couple of years again. And that sounds great. Let's see what happens. All right, Liz, thank you so much for being here. This was great and it was fun. I learned a lot. So thank you for your time and for sharing your experience. And also thanks everyone else who is watching and listening. Thanks for watching and listening. And until the next time, thank you very much. Thank you for having me. Have a great day. Bye-bye. Thank you.